Welcome to the Enhanced Emergency Sexual Assault Services, or EESAS training. My name is Kathy Carter-Snell. I'm faculty in the School of Nursing and Midwifery at Mount Royal University, and this is Module 1 of 8. This is an overview of sexual assault issues and the EESAS. In this unit, we're going to look at trauma-informed services and some of the underlying myths that impact how we provide the care, and the impact of sexual assault on healthcare, vulnerable groups, and how we as professionals can further impact their victimization. And then we'll look at the key principles of the EESAS model and the focus of sexual assault services. So what are trauma-informed services? It's recognizing the impact of trauma on lives and health. So it's not just recognizing the injuries and providing the trauma care in the emergency department or at the scene with the victims. It's recognizing the psychological, physical impact of the trauma on their relationships, on themselves, on the community and society. And by doing that, we can then provide support and understanding. We may not recognize that the person that is in the emergency department with abdominal pain not yet diagnosed is actually having somatic pain from a sexual assault when they were 12. And so understanding that will help inform what we do and aim our interventions at the right root cause. And it's also allowing us to work collaboratively with other disciplines and organizations, because the trauma-informed services is more than just the professionals delivering the care understanding the impact. It's also from an institutional perspective, how your department is designed, the policies and procedures, the having staff available, providing support for staff to receive training such as this so that everyone understands, developing collaborative networking with agencies that will interact with the clients. The key goal is to emphasize safety for both consumers and providers. The more you understand about what to do and why to do it, the better care you can provide and the more comfortable you are and the more safe you are in providing that care or support. And above all, it helps survivors to regain their sense of control and empowerment. Some of the myths and realities that impact how we understand the trauma are really important. First of all, we often hear she didn't say no, or he didn't say no, recognizing that it can affect both genders. But we've seen this in recent trials with media celebrities, where they say, well, she didn't appear to say no. In fact, the criminal code says that in order to consent to sex of any sort, you must say or indicate yes. In the younger generation, we hear them saying an enthusiastic yes. So it doesn't mean a written contract, but something that you have said or done clearly indicates, not suggests, but clearly indicates that you're interested in the activity. That it's about what he or she wore. Sex offenders, in fact, say that they have no idea what the victims wore. It was that they were accessible and that they were vulnerable. And yet that we perpetrate this myth on a regular basis. That it was the victim's fault that they were drunk. In fact, offenders use this as a tool. They know that the victim will be blamed, and providing them with liquor is a socially acceptable way to make them more vulnerable. And so they use that as their tool. What I tell my clients who are often feeling guilty is that, yes, you perhaps could have seen it coming or could have avoided, but it was still the other person that did it to you. And the example I use is if you were drunk and somebody hit you over the head with a hammer, does that make it your fault? No, you were drunk, you might have avoided it, perhaps, but they still targeted you and hit you over the head with a hammer. It doesn't take away the issue, but getting into a lecture about not getting drunk is only going to make them feel more guilty. And ultimately, it's the assailant's responsibility for the assault, not the victim's. That they would report it if it was real. In fact, repeated Statistics Canada surveys show that only 10% of the people reporting sexual assault or disclosing sexual assault in community surveys report to police. This is different than police statistics. The community surveys are a little bit better because they go into all households. They're still not ideal, but the statistics, if you only go off crime reports, are quite different. But of the people in the community who have been sexually assaulted, only 10% reported to police. 30% of them will seek healthcare. So healthcare personnel have 3 times the opportunity to interact in a positive manner with victims after sexual assault and opportunities to connect them with resources, including police. We find a high rate of reporting, much higher if they seek healthcare. We don't want to force them to report, but if they understand their options, they can make more informed and clearer choices. That they'll seek help promptly. In fact, this is a huge issue. They will feel guilt. They'll be blaming themselves, especially if they had alcohol or drugs. They'll want to let that clear their system so they can think clearly. They need to reflect on it. They may not know what happened and have to call a few friends. About 70% of them will disclose to a peer, which is why it's really important that peers know what services are available in a community, and about 30% will disclose to family. But the majority of people that come in seeking health care, in my experience, have been encouraged to do so by a family member or by a peer. So it's at least 12 to 24 hours in the Alberta data that I have. But in the US data, they're finding even more than 24 hours before people will come in. So that doesn't make it any less real. It is often more a reflection of the inner struggle that they're having in deciding what to do. If they've had more than one assault, in fact, it's very frequent. As many as 70% of people will be re-victimized, particularly if they develop PTSD and abuse substances such as alcohol or drugs to try to avoid the feelings that come along with their recollections of the assault. So teaching positive coping responses and providing appropriate support can potentially prevent the PTSD, therefore decrease their risk of victimization. False reporting. In fact, we always say that, well, what if she's lying or what if he's lying? In fact, the US studies have shown that only 2 to 8% of sexual assault victims lie, and Canadian stats from a Statistics Canada survey show that the rate of false reporting is the same as for any other crime, which is 2 to 4%. Therefore, 92 to 96% of people are telling the truth, which is why it's extremely upsetting to hear that we are using words like alleged sexual assault when they come in, when the majority of them are telling the truth. Furthermore, alleged is a legal term, not a medical term. We don't say an alleged motor vehicle collision or they have alleged chest pain. Therefore, we should not be using that term with these people. It conveys that we don't believe them. That males can't be victims. In fact, at least 1 in 6 males, probably 1 in 4 males are victims, but gathering data is very hard to do. There's very limited data available, and males are even less likely to report than women are. The assailant is usually a stranger. In fact, the vast majority know the victim. 70 to 80% are assaulted by an acquaintance. So that's not even counting intimate partners. So somebody that they've met recently at a bar, or they've started becoming interested, or it could be a friend of a friend or a co-worker or somebody in their sports world. And another 10 to 15% are assaulted by intimate partners. There's a really gray area in there because if you met somebody at a bar and go out with them on a date, that's not always counted in statistics as an intimate partner. But in committed relationships, it's about 10% of the population are assaulted in committed relationships that we know of. And then there's about 7 to 10% that are by strangers, and yet we keep teaching stranger danger when it's in fact the people that you know or are with. Often perhaps staying at somebody's house after drinking so you don't drive. And many young girls are waking up and they've been assaulted in the It's important to point out that most men are unlikely to offend or to become sexual assailants. And so therefore it's really important to involve men in helping protect people who are vulnerable and to involve them in prevention activities rather than making them feel blamed or shamed. The risk of offending across time in a longitudinal studies by Thompson's group found that about 20 to 30% of men were likely to commit sexual assault at least once across their 4 years in university. An even smaller percentage of those men were considered serial or persistent offenders. In Lysak's work in 2002, it was about 4% of the men responsible for 13 assaults each, so about 5 sexual assaults and 6 or 7 domestic violence or child abuse incidents each, and were undetected. They were seen as good college boys. and 9% of men in two other studies had raped in both of two time periods that were studied, so they were considered persistent. Some of the common characteristics between all of these studies were that the men had hostile attitudes towards women, they supported rape myths, there was also evidence that they misused alcohol or had high alcohol use, and they used predatory behaviors in Lysak's work in which they sought vulnerable individuals, either incapacitated with drugs or alcohol, separated them from their friends, and then used alcohol to gain access to them or to make them more vulnerable. So important information in setting up prevention and understanding the mechanisms that happen. So we need to start to challenge our perceptions and our beliefs because this impacts how we treat our clients. If we treat our clients blaming them, we had a young girl go to one emergency in one city, and was with her boyfriend and had ingested some magic mushrooms, and he sexually assaulted her. And when she got to the part to tell the emergency nurse about the magic mushrooms, the nurse looked at her and said, "Girl, what were you thinking?" The girl got up and she got out and went home, and 2 days later attempted to commit suicide, which is how I heard about her through a friend of a friend, and I met with the young girl subsequently. But it would have been very easy to swallow that retort. Sure, it's not a great idea to have magic mushrooms, but that's after the fact, and that still does not make the assault her fault. So we need to park our reactions and understand that not everybody makes great decisions, but that still doesn't make it their fault. The costs, if we treat them in a negative manner, are massive. And so the I Believe You campaign that's kicked off in Alberta this summer in 2015, and the Start by Believing campaign that started approximately 2 years ago in the US are extremely important campaigns for public, for the professionals, for the police officers, healthcare professionals, social workers. Start by believing most of them are telling the truth, and by treating them negatively, then that seriously impacts their risk. Violence accounts for at least a third of the dollars spent on healthcare in the U.S. and Canada. Billions of dollars are spent on not only the healthcare, but the support services, the counseling, the sexually transmitted disease treatment, and then the long-term consequences. So, which I'll talk about in a minute. So it's linked to significant repeat emergency visits, particularly if they are not assisted to cope in a positive way after the assault. So it affects all of us, not just the victim. The victim in the short term may have injuries, although that's unfortunately used a lot in court as to whether it's a real sexual assault. In fact, 30 to 50% of women may not have any injuries at all after a sexual assault. It depends, in the research I did, on whether they were intoxicated or whether there was resistance, the relationship of the assailant. People who are assaulted by strangers or intimate partners tend to have more injuries, but people who are assaulted by an acquaintance or somebody, a friend, tend to have less injuries, and particularly because alcohol or drugs are used to make them more vulnerable, so they're not fighting back. Most of the body injuries come from that. They have risks for sexually transmitted infections, particularly if no condom is used or there are genital injuries present. And they may not know without an exam that there are injuries. So many people going to police and not going to healthcare will say, well, I'm not injured. But at least only 17% of women in a review I did of the research that had injuries had pain with those injuries. So if you don't get a physical exam where there's palpation to look for tenderness, you won't understand that there's injuries there. There's also risks for pregnancy. Long-term, high risks for acute stress disorder, post-traumatic stress disorder. About half to 60% of men and women will develop PTSD after sexual assault. Many of those will also develop depression or anxiety. They may not ever get diagnosed, but you'll see patients have high numbers of anti-anxiety pills, antipsychotic, beta blockers, sleeping pills. Chronic health problems, high rates of cancer, heart disease, autoimmune disorder associated if these stress disorders develop. So they're not just mental health or physical health problems if we can't bypass their risk or promote their resiliency. Suicide attempts, really high risk as well. We mentioned the re-victimization. There's also problems with intergenerational trauma. People who have suffered abuse or assault and particularly if they develop depression or PTSD, their children are more likely to develop these disorders as well. And somebody who has adverse childhood experiences, we know from the ACE studies, is higher risk to be bullied, is higher risk to be sexually assaulted, higher risk to be in an intimate partner violence relationship. And the cycle keeps going on if we don't show them ways to cope and be resilient. So the consequences for the individual are dropouts of school. Very high, a lot of the population is at school age, so senior high or university age. Loss of employment or lower level of employment than they would have had. They might have been pre-med, pre-law, and they drop out and they work at a convenience store. And relationship problems, having difficulty making attachments, particularly if they lost trust in the people around them. So at least 500,000 people, Canadian women in 1 year, reported sexual assaults, and we know that if only 10% report, that could be as much as 4 million in 1 year were assaulted. Another Statistics Canada study found that 1 in 2 women over 16 had had at least one episode of unwanted sexual contact. So the conservative estimate is 1 in 3 women are sexually assaulted, and a conservative estimate for men is 1 in 6, but could be as high as 1 in 4. And because it has such a high rate of psychological and long-term health consequences, that gives us an idea of the magnitude. But many people are coming to emergency with problems other than sexual assault, and we're not linking it back to that. As I indicated, it might be abdominal pain not yet diagnosed. We label them as drug seeking because we can't find a cause for the abdominal pain and don't ask about a previous history of violence. We don't recognize that the suicide attempts are related to prior experiences of violence. So universal screening of all ages and both genders for previous histories of violence, not just current, but previous histories of violence, can inform our health care and how we're responding to these people. So who's most vulnerable? Sexual assault is often called gendered violence because females, particularly between 14 and 24-year-old, are most vulnerable. Particularly in times of trauma, so floods, high unemployment, disasters, tornadoes, and it's used as a weapon of war as well. Children of either gender up to age 12 are equally at risk for sexual assault and sexual abuse. And then other vulnerable populations, our Aboriginal population, extremely high risk for it, again, from intergenerational trauma, parents who've been victims of the residential schools or grandparents, the abuse and neglect and difficulty parenting, the alcohol and substance abuse are all symptoms of the trauma. We aim our treatment at the addictions when in fact we should be aiming our treatment at getting them linked with people to help them with coping with the trauma itself. Disabled people physically or mentally, elderly people who require care, whether it's in their own home or in public settings, are extremely vulnerable and less likely to report it. And those who are incapacitated with drugs or alcohol are all vulnerable. So what's our impact? A study that was done of healthcare professionals and police, as well as clients, found that the healthcare and police professionals thought that they had helped the person and that they had a positive impact. This is in an area, in an emergency department that didn't have dedicated services. And yet more than 80% felt violated, bad about themselves, and unlikely to seek help again. So if you're feeling bad about yourself, that's a risk factor for developing PTSD. And so therefore you're more likely to be re-victimized, but now you feel that you're never going to seek help again because of the way you were treated. So then that whole cycle of chronic health issues begins all over again and re-victimization. So we need to find ways to treat in a more sensitive manner. Treating them, causing more problems for them is called secondary victimization. We're making their trauma worse. And many of these settings, issues in emergency can do that. So long waits in the emergency, incomplete range of services. They come to one agency and they get told they have to go to another. Or I can only do the sexual assault care here, but you have to go there for the x-rays or the blood work. They're unlikely to go to the next place. We find that only about 30% of people will return for follow-up. And we found in places where there's a central sexual assault center and they report to, say, a hospital in the outlying area, we actually have people that will not go to the second hospital. So some departments actually have volunteers and taxi chits and they accompany them to the next hospital to support them. Treating them with disbelief, victim blaming, or focusing on our time rather than the needs of the client. So I've only got a few minutes. I need to hurry through this form. So if you can make sure that the person that's treating them has a little bit of extra time, or if you don't have time, get them comfortable, provide comfort measures, and tell them that you will return when you can spend some more time with them. If you have to have delays, then at least explain why they have the delays. Otherwise, they're feeling that you're avoiding them and being stigmatized. Taking control, telling them what they have to do. Reporting to police for most people is optional. We talk in one of the other units about mandatory reporting. But the majority of people, it's optional. And it may in fact cause more harm than good, or if they're forced into doing it or coerced by the staff, they're unlikely to follow through with the system. So they need to have informed choices and then make the choice for themselves. And we need to park what our priorities are and not impose those, because we don't live in their life. We don't know what's best for them. Telling them to get over it or move on, or how lucky you are that you survived. They're not feeling lucky. They just got sexually assaulted. Or stigmatizing them or labeling them as the sexual assault in bed 3 rather than Mr. Jones or Miss Jones in bed 3. And a lack of support. The provision of informal, said through family or friends, or formal support is one of the biggest factors that can reduce the risk of PTSD and promote healthy recovery. So some of the conditions in the emergency automatically create those delays. If you only have one emergency physician on, it's hard to pull them out for 3 hours if you don't have dedicated sexual assault physicians or examiners. There's varying quality of care. It's about the only procedure in the world where it's okay to read the instructions on the sexual assault kit while you provide the care. And so people tend to avoid it. There could be delays in waiting for a private room to treat them and the discomfort of all staff with the procedures. If you're in a smaller hospital, it's even more likely that they'll receive substandard care, not from a lack of skill of the professionals at all, but because they have even less resources. So there's more delays. There's less comfort with the procedures because they may only see a few patients a year and may not always be the same staff doing it. There may be limited telecommunications for the patient to even get to seek police or healthcare staff. And if they do show up, often they get transferred out of their community to a larger community that might have dedicated services, which takes them away from their support people. It also means that in many cases they have to ride in a police car. So if they weren't planning to report now, they pretty well have to because they're going with them. They may not be able to access victim services if they don't report to police, and that might be the only support they have in a very small community is the RCMP victim services. And the healthcare staff have told us in our rural study that we did that even though they're a little uncomfortable with the procedures, they would rather have the patients remain in the community because they know the support services, they know the culture of their community, the cultural resources that they have, and when they go to the city and come back out, they don't know what kind of follow-up care they need because there's very little communication with the urban centres. All of these were the reasons for the enhanced emergency sexual assault model. The model is to enhance the existing skills of all the professionals so everybody feels more comfortable. There's things that we can do within our scope of practice without having to be specialized that can reduce the delays, reduce the secondary victimization, and increase all of our comfort with providing the services. So all professionals, police, social workers, healthcare professionals, receive training on positive responses to disclosure and support, the need for systematic documentation, evidence collection principles, and consistent injury terms. Work with them to appropriate to the community to identify the best model of service. So the patient arrives in emergency after a recent sexual assault, which is defined by each community. It used to be only 3 days, but we know that we can treat now with the morning after emergency contraception up to 5 days. So if there's still a need for health care. And evidence collection in some instances may be as valid as long as 7 days. The cervical mucus can retain semen or sperm up to 5 to 7 days or perhaps even more, and we have better testing techniques. So the skin evidence would be gone, but perhaps it's worthwhile doing a vaginal sample. So when they get to triage, we look if they're unstable or emergent, and if not, If they are, clearly we have trauma care has to be provided and evidence preserved. But then if there's a sexual assault examiner or a physician examiner, then we would call them, and if they can provide a response soon, then the staff would put them into a private area, provide them with comfort measures, see if they need any support people brought in for them. If there is a sexual assault examiner or physician examiner available, but they're going to be delayed, they might be seeing another client, they might be storm staged, any number of regions, then the staff can provide supportive measures and not be as worried about ruining evidence. Because in most cases, it's not that they don't want to provide the care. They are doing the very best they can, and they have the concerns that they're going to destroy evidence. So it's more about how the patient is supported, really. So they can safely provide supportive measures without disrupting evidence if they have this knowledge. And they might consult with the sexual assault examiner as to what can be done while they're waiting. If it's going to be an extensive wait, then the staff could go ahead with the EESAS model and implement that and collect and preserve the evidence so that the patient can go home and begin their healing journey. If there is no examiner available in the community, then they can provide supportive interventions and implement the EESAS. The ESAS is really building on existing skills. The triage nurse is already triaging using the Canadian Triage and Acuity scale. They may receive urine samples if the patient has to void at the triage area, and they're doing suicide screening and crisis intervention and links with the support team or the sexual assault team if they're available. What we're adding to this, drug-facilitated sexual assault, the sooner we get the samples, the better. To test them, because if there is an agent, and only about 4 or 5% have agents other than alcohol that are the traditional date rape drugs, but if they do have them, they're gone in about 12 hours. So the sooner we can get the blood and urine, the better. So if there's a potential that they don't remember what happened or they meet the criteria, we talk about that in another module, then the triage nurse will hopefully have protocols to allow them to obtain the blood and urine at triage, and then they maintain custody of the samples either in a locked drawer or with them at triage until they decide whether a kit's going to be done based on the patient's wishes. Then when the patient gets into the treatment area, if there's no SANE, then the staff already provide crisis support, do the medical history, do a head-to-toe exam, provide interventions and discharge teaching, and collaborate with the physician on interventions. So what's new with this? We're going to get them to do the informed consent for the sexual assault exam, which just explains the components of the exam. They ask a few guided questions, which is all spelled out on the sexual assault history form for the RCMP kit. And they collect evidence, which consists of taking a couple of Q-tip swabs from any stains or areas of ejaculation, a mouth swab, collecting the panties, and maybe fingernails if they scratch swabs if they scratch the person. They maintain chain of custody on those samples. They keep them with them or put them in a locked area until the gynecology exam is done or the genital exam for male. And then the physician already knows how to do the speculum exam, so we don't have a big learning curve with the nurses learning this and having to maintain their skills. If you're going to do speculum exams, you have to see a certain amount of normal exams as well as abnormal to be able to differentiate normal findings from abnormal. So that's very hard to do in a smaller community. So the physician, instead of being pulled out for the whole exam, is only being pulled into the room for the gynae exam, obtaining the genital samples, and ordering the medications, all of which he or she would normally do. All we're adding to their role is the enhanced visualization techniques for the genital injuries, and perhaps a little bit more information on the few swabs that we do. We only do a few swabs in the genital area. So all of this is within their scope of practice. All of the emergency personnel are brought up to speed. The police, the social work, pastoral services may not want to watch the modules on the body exam and the genital exam because there are graphic examples of injuries, but they're welcome to do so if they would like. It's restricted to professionals working with victims of sexual assault, and the information will hopefully be treated in a sensitive manner, but they're all welcome to participate. Then hopefully we will link them with a sexual assault expert. If there's not one in the community, some communities only have one SANE who is only obviously able to do 40 hours a week. So the other shifts, the emergency staff do the exams, But the sexual assault nurse examiner can provide training, can provide quality assurance, peer review, and help support them when he or she is not there. Or if you don't have one in the community, then it helps if your organization can link with a sexual assault nurse examiner team in another community. Often at 3 in the morning, it's a matter of calling somebody that's on call, a SANE in another community, who's already on call, working 24, they work 24/7 in the cities, and asking them, this is what happened, what kind of samples would you recommend? Because you don't do the same samples on everybody, it depends where they were touched or contacted. Or what would you recommend STI treatment in this patient with this type of contact? A 5-minute phone call and everybody feels more comfortable. I did that in one northern community, and within 6 months everybody felt comfortable with the treatment they were providing and they felt supported. Then in addition to that, you need a sexual assault response advisory group, which is all of the community agencies, including the healthcare, police, Crown prosecutors, and any other support agencies in the community, who meet probably 3 or 4 times a year. Initially, it might be more frequently. Well, they develop the policies and procedures to support. For instance, if the patient's going to be delayed more than 2 hours before being seen with CTAS guidelines, then get that the emergency staff will initiate the EESAS, or that how they collaborate with the SANE in a nearby community, or how people will be trained in particular areas, or even that people will participate in the training. So your advisory team is really important. It also helps as you go along to work out the kinks if there's communication issues between the disciplines. So the initial training consists of 8 half-hour modules, approximately half hour, each with a little quiz. So it takes approximately 4 hours to complete the whole training, and they get a certificate if they complete all 8 modules. Then if in some communities they want in-person training, which we can do, and then but then anybody who can't attend could take the online training. So you can still get all of your staff trained. Then there's also approximately 40-minute DVD of evidence collection and highlighting some of these principles. So it's an abbreviated version with a quiz available, which can be used for annual recertification. Any updates will also be put on the Forensic Education website, and there could be on-site training as well for that. There's also a brief checklist for supply carts that's been developed. The manual that goes with the RCMP kit is about 16 pages long, and so this is just a quick checklist as to who can do what and what step is next in the sequence. So the benefits are that the patients, if they're treated more promptly and they receive comprehensive care that's supportive, will experience less stress. Therefore, there's less risk of stress disorders such as PTSD and depression, less substance abuse, less unemployment, and less re-victimization, and they receive timely access. The staff benefits are reduced wait times in the emergency, reduced stress on the staff if they know what the protocols are, which can ultimately all work together to decrease repeat emergency visits. The emergency visits can be 4 to 5 times higher after sexual assault compared to people who haven't been assaulted. And all of the skills remain in your existing scope of practice, so nobody has to learn new certification or transfer of skills. So the trauma-informed services, understanding the impact that this can have if we don't treat them sensitively is really important. The treatment must include restoration of control and dignity, a recognition and treatment of health risks, and organizational professional commitment to best practices. It may include involvement of police and evidence collection. And just remembering that prevention of the psychological harm, even though evidence is really important, the prevention of psychological harm is even more important. And if you can treat them sensitively and provide formal and informal support resources for them, they're more likely to follow through the legal system if the police are involved. So recognize that sexual assault has long-term health consequences, but we can reduce those if we provide comprehensive sensitive care. And EESAS is using existing knowledge and expertise and collaboration with sexual assault experts. If you have further questions, you can contact me at mountroyal.ca or at our website, forensiceducation.ca. I'd like to thank Prince Edward Island Advisory Agencies. They were the ones that helped develop this initial set of modules, particularly some key agencies throughout the province that have continued to be of support. Funding has been provided in part by Association of Alberta Sexual Assault Services, Status of Women Canada, and Mount Royal University. Many thanks.